Hi everyone, it's almost 2 minutes after the hour, so I'll go ahead and get started to make sure that our presenters have enough time for their presentation. Welcome everyone. My name is Abdallah Ammar. I'm a neurocritical care pharmacist specialist at the New York Presbyterian Weill Cornell campus, and I'm excited to be the moderator for the NCS Pharmacy section this month. Other moderators with us today is Dr. Karen Berger from Nova Southwestern University and Dr. Kimberly Franklin from Tufts Medical Center. Just a quick few announcements before we get started. Thank you again for everyone who joined us, and they are muted at the moment. But just a reminder to make sure you remain muted while the presenter Journal Club. We will save some time at the end of each presenter's presentation for questions and discussions about their individual article. We have two presenters today who we will present two separate articles. You can join us by listening to the presentation through the Zoom here, but you can also follow us along the Twitter using the hashtag NCSPharmJC. Again, that's NCSPharmJC. On the Twitter, there'll be an active discussion about these articles. So if you want to participate, direct discussion with the presenters or the other who join through the Twitter account, feel free to do so. Our first presenter is Dr. Jana Antinon, who is a PGY2 critical care resident at the University of Tennessee Medical Center, who will be presenting on the direct oral anticoagulants or DOACs and anti-seizure medications for atrial fibrillation and epilepsy and risk for thromboembolic events. Dr. Jana, if you can take over and present your slides.
Yeah, give me 1 second. Thank you for that introduction. So like you said, my name is Gianna, and I'm going to be presenting on direct-acting oral anticoagulants and anti-seizure medications for atrial fibrillation and epilepsy and the risk of thrombotic events. So before we get started, I just wanted to include an abbreviation slide for completion's sake, since I will be using some abbreviations throughout this presentation. So this is easy to refer back to if you had any questions. So getting into some background of the topic, more than 70 million people worldwide have a diagnosis of epilepsy. Atrial fibrillation is also the most common arrhythmia, affecting approximately 2.7 million Americans. So the idea of this study was to look at the drug interaction between direct oral anticoagulants and enzyme-inducing anti-seizure medications, which have been shown to lead to a possible increased risk of thrombotic events. And in the United States, we commonly use non-enzyme inducing anti-seizure medications, have kind of where our practice has evolved to. However, in middle and low income countries, enzyme-inducing anti-seizure medications really do remain the standard of care for the treatment of epilepsy. Expanding more on that interaction, it's all through our CYP P450 system. So as you can see, dabigatran is not metabolized through the CYP system. However, rivaroxaban, apixaban, and endoxaban are all metabolized through the CYP3A4. And then with our anti-seizure medications, we have some different medications that can also interact with that P450 system. So we have inducers and inhibitors. So here are inducers: phenytoin, topiramate, oxcarbazepine, felbamate, carbamazepine, and primidone. And as inducers, these can cause subtherapeutic drug concentrations, potentially leading to more clotting in these patients. And our inhibitors, like valproate, topiramate, and oxcarbazepine, can cause supratherapeutic concentrations, which can lead to more bleeding. There has been some background literature specifically on animal models that have looked at the different concentrations when these agents are used together, and there's been really varying results of whether the enzyme-inducing anti-seizure medication does affect the levels of the DOAC or not. So here I included one study that was a retrospective cohort study that looked at the risk of subtherapeutic concentrations with DOACs when used with enzyme-inducing anti-seizure medications. So this had 307 patients, and again, they compared the peak plasma concentrations. And when the apixaban was combined with the enzyme-inducing anti-seizure medication, the peak concentration was significantly lower. And just for reference, a 5 milligram twice daily apixaban dose usually results in a peak concentration of 91 to 321 nanograms per milliliter. So you can see that enzyme-inducing one is closer to that lower end of that therapeutic range. And at hospitals, at least at my hospital here at the University of Tennessee, we commonly don't do peak plasma concentrations, but I just wanted to include that for your reference just to get an idea of what a normal level would be. So that brings us into our research question and what the designers of this study were wanting to look at. So their main question was, does the co-administration of enzyme-inducing anti-seizure medications lead to an increased risk of patients having thrombotic events? Expanding on our study design, it was a retrospective cohort study done in the United States at the University of Pennsylvania. They included an active comparator group to try and limit the bias with it being a retrospective study. So the active comparator group included patients who were adults aged greater than or equal to 18, had to have a diagnosis of epilepsy and atrial fibrillation, and an exposure to a direct oral anticoagulant with a non-enzyme inducing anti-seizure medication, since our exposure group were the ones that were on that enzyme inducing anti-seizure medication. And they also did propensity score matching just to try and match patients as closely as possible to, again, try and limit bias based on baseline characteristics. Here I mentioned we had an exposed and a referent group. So here I wanted to include a slide listing what they included as enzyme inducing and non-enzyme inducing. I do want to mention that there are some other agents that can be considered enzyme-inducing anti-seizure medications. However, this is solely what they used whenever they were doing the retrospective study. So these were the only agents they looked at. So in the exposed group, as I mentioned, they were on an enzyme-inducing anti-seizure medication as listed here, plus a direct oral anticoagulant. And the referent group, or the active comparator group, was on a non-enzyme-inducing anti-seizure medication plus a direct oral anticoagulant. Here, I think this gives a really good depiction of kind of what the study looked like. So there was a baseline period of 3 months prior where patients were on either an enzyme-inducing anti-seizure medication or non-enzyme-inducing seizure medication. And then they were started, so these were all new start direct oral anticoagulants. And they looked at these patients based on if they were compliant with their medications, and then they observed them for 1 year. And their outcomes of this study, they looked at primarily the risk of thrombotic events, and their secondary outcome was the major bleeding event. Here are some demographics. There was nothing really too significant between the two groups, since they did do that propensity scoring and they used that active comparator to kind of limit the bias. So here I just included the age. They were older patients. Male versus female wasn't significantly different between the two groups. The majority of these patients were of the white race, and about 20% in the referent and 15% in the exposed group had a history of having an ischemic stroke. Additionally, they did censor patients. So this means that they observed patients for 1 year. However, if these patients had any of these, they would look at them prior to that. So like a thrombotic event, which they defined as an ischemic stroke, a venous thromboembolism, or a myocardial infarction, or a major bleeding event requiring hospitalization. Also, if there was a discontinuation of dispensing of the direct oral anticoagulant or enzyme-inducing anti-seizure medication, or the non-enzyme-inducing anti-seizure medication based on what group they were in, or if there were unavailable prescription claims due to hospitalization within a 14-day grace period between dispensing of prescriptions. And this they did to account for imperfect adherence or brief hospitalizations. And then also change in insurance status in which claims were no longer available in the database that they used. And patients included in this study had claims at large commercial and Medicare Advantage health plans. So if that had changed, they might not have had that information within the database. As for statistical analysis, they did use incidence rates, which was just looking at the number of patients who had an event within 1 year. And they reported that in-person time exposed to DOACs with a concurrent, either if they were in the exposed group or the referent group. They also looked at hazard ratios, propensity scores, where they used the nearest neighbor matching, Kaplan-Meier curves to look at event-free survival, and then Cox proportional hazard regression models. I did also want to mention that on top of the propensity scoring, they used covariates, and this was again to try and adjust for confounders, and they looked at different comorbid conditions that could increase their risk, such as cancer, histories of ischemic stroke, venous thromboembolism, whether they have prosthetic heart valve, renal failure, and also comorbid conditions like other CYP P450 inhibitors or inducers, estrogen-containing agents, thrombolytics, NSAIDs. And the propensity score matching was based on 36 investigator-selected covariates and 490 empirical covariates. So they were very well matched throughout the study. Getting into the results of the study, a total of 14,078 episodes were discovered where patients were on an anti-seizure medication plus a direct oral anticoagulant. Then further deciphering them in the exposed group, there were 3,798 individuals. So again, these were patients who were on a direct oral anticoagulant plus an enzyme inducing. And then the referent group had about 10,000 patients. And these were patients who were on a non-enzyme inducing. After all the propensity matching, they included 6,420 episodes that were eligible to be included. Here, getting further into the results, I do first want to orient you to this, this chart. So this chart we're going to look at in two different slides. So just don't mind the title here. I did break it up into 2 slides. But as you can see on the left, these were unmatched episodes. So here it looks like there was a difference in thromboembolic events. However, when you look at the right side here, circled in the red, you will see that there was no difference in thrombotic events between both the exposed group and the referent group after matching. And here is a Kaplan-Meier curve just to give more visual representation of what that chart was showing us. So I do want to mention on the right side of this screen, this is just a zoomed in picture of what's on the left. So as you can see, when they get to this 1 year line, it does look like there becomes a difference. The designers of this study did mention that in their discussion. However, they did want to mention that they only observed these patients for 1 year. So that really, after that 1 year, that difference really wasn't looked at in this study. So that's something that can definitely be looked into further. And then here is the other half of that chart looking at the major bleeding events. So again, here on the left, there is the unmatched group, and then on the right, there is the matched group. However, there was a significant difference here in patients in the exposed group having less bleeding than the referent group. But that doesn't technically mean it's clinically significant. As we know, in the exposed group, they were on those enzyme-inducing agents, which could have led to less direct oral anticoagulant in their system. And here again is a Kaplan-Meier curve looking further at that chart to show us that there was a difference between the major bleeding between both the exposed and the referent group. Here, just another slide showing some different results that they had found. Really nothing different on the thrombotic events, as we mentioned. However, I do want to comment on the last one, all the way at the bottom on the left, at the greater than 180 days, being an increased risk of event. Again, that could be at that 1 year mark, where they didn't look further into that. And then for major bleeding being statistically less bleeding in the exposed group. They also did some secondary analysis where they looked at anti-seizure medications commonly dispensed for non-epilepsy indications, so like topiramate, gabapentin, and pregabalin. Also weak 3A4 inducers, like high-dose topiramate and oxcarbamazepine, and then levetiracetam, exposure in the referent group, and they found that the results were consistent with the main analysis as well. Going into my critiques of this study, I think that there were strengths, definitely the propensity scoring. I think that the patients were very well matched with all of the propensity scoring and the covariates that they used. It also was a large study group, which is always good when trying to look at trends. However, limitations, it was a retrospective study in a cohort design. As we know, our randomized controlled trials are going to be our gold standard. However, that isn't really going to be ethical for these patients if there is that potential risk of the increased risk of thrombotic events and increased risk of bleeding. So retrospective kind of have to do what we can with retrospective. Also, their inclusion, they limited patients to a diagnosis of epilepsy and atrial fibrillation. Could this have affected patients differently who were on it for, say, a venous thromboembolism or any other reason? So we were really only looking at a niche group of patients who only had epilepsy and atrial fibrillation. Some medications included for other indications other than epilepsy, which they didn't, they only looked at patients who had a diagnosis of epilepsy and atrial fibrillation. However, if a patient was on multiple medications, it could have been hard in a retrospective study design to decipher which one they were using for epilepsy and which one they could have been using for another indication. And then they also did not comment on the CHADS-VASc score for these patients. So it could have potentially been different if all of these patients had a CHADS-VASc score of 2, which we know that they have a lower risk than a patient who has a CHADS-VASc score of 5. So I really would have been interested to see what their CHADS-VASc scores were for these patients and if they were consistent throughout the patients. As for the author's conclusions, they don't really give much suggestion to their conclusion of this. They really state that the results of the study may suggest that there is a pharmacokinetic interaction between the agents, leading to lower DOAC therapeutic concentrations to a degree of lowering the risk of major bleeding without an increased risk of thrombotic events. As for my interpretation of this study, I think that short-term use of a direct oral anticoagulant and an enzyme inducing anti-seizure medication should not be a concern for providers. We saw that when they had newly started a direct oral anticoagulant and when they observed them for a year, there was no difference in that thrombotic events. So I know that this study didn't look at patients taking it for venous thromboembolism, but that's kind of what I would take out of this study, is that in the short term, there wasn't an increased risk. There also is still controversial data to support the long-term use of these agents. If you remember from that one chart, we saw that there was a difference after 1 year. However, the study designers did not look into that 1 year. So there's still some further analysis that could be done with that 1 year. And then patients with that long-term use, that leads me to think that we should be weighing the risks versus benefits for these patients. So as pharmacists, especially in the US, we commonly use enzyme or non-enzyme inducing anti-seizure medications preferred over enzyme inducing because of their ease of dosing. You don't have to monitor levels. They also have a more favorable side effect profile. So I would say that non-enzyme inducing anti-seizure medications, if we can use them, that would be the best option. However, as pharmacists, what do we do with that information if our patient has to go on some sort of anticoagulant? So again, for short-term use, really not a concern for increased risks. However, long-term use, if a patient is going to be on an anticoagulant for long-term and they are on an anti-seizure medication lifelong, we really should be having that conversation with the entire team. So getting the neurologist involved and really weighing out the potential risks versus benefits of what's going to be the most beneficial for the patient and be the safest for them. And that's all I have. I'm happy to answer any questions that anyone may have.
Thank you, Jenna, for your representation. It's a very interesting topic that I usually ask myself how significant is drug-drug interaction. So everyone feel free to post your questions in the chat, but I will go ahead and get started. In practice, we change anti-seizure medications between agents, especially when you have complex cases. Did the authors in the study account for changing between these anti-seizure medications from both groups, whether in their design, or did they address it during the study?
So the only thing I could find in this study is that if they had changed anti-seizure medication, they would flip groups depending on which seizure medication they were. So they did account for that. How far they looked into that, I am not entirely sure, but they would move them to a different group depending on if there was a change in their agent.
So you have a question over here. That's interesting regarding risk in VTE treatments. I would think that patients on an acute DVT-PE may be a higher short-term risk of thrombosis than patients with arterial fibrillation. I'm not sure I can extrapolate these results. Would you be okay with overlapping the enzyme-induced anti-seizure medications with DOACs for acute DVT or PE?
So I think overall, if we can avoid the enzyme-inducing anti-seizure medications, that would be the safest option for our patients. But if you cannot avoid it, I think that based on this study, in the short term, it did not show an increased risk of thrombotic events. So if they're on the short term, I think that still should be had a conversation with both the patient and the neurologist, but I'm not as inclined within the short term as a need to change their anti-seizure medication if they have been controlled on it for a very long time. However, if they're going to be on it for a longer period of time, I definitely think that becomes a bigger discussion. I'm not saying that there isn't a risk, but I definitely think that involving the neurologist and having a conversation with everyone is really the best option, and using the non-enzyme inducing anti-seizure medications when possible.
We have another question. Do you think there's any role for measuring DOAC levels in this setting? I was actually thinking about the same thing. Did the study or the authors actually assess levels for these patients in terms of the anticoagulations?
No, the authors did not. I don't think that it's very commonly done, and it's not something like, as a pharmacist, if someone got a DOAC peak concentration, I'm not sure I would know what to do with it, just because I haven't done that, and that's not commonly done in practice. So at this point, I don't believe that there is, but maybe in a long-term patient that might be, the neurologist is very insistent that they have to stay on their anti-seizure medication. That might be a conversation to have, but in a routine patient population, I don't see a need for it at this moment.
Yeah, also on the other hand, I think that measuring DOAC levels is getting more common. So I think there's maybe a value for measuring it in terms of long term, where you can assess. Maybe perhaps in short term might not be important, but I think if it's chronic use of DOACs, probably there might be a use of getting levels as well. Did the authors comment on whether other enzyme inducers or inhibitors may have been started after the DOAC initiation, or did they assess the initial anti-seizure medications?
No, they did not comment if any of them were added. The only thing that they did was in that covariates, they tried to match people the best that they could based on current medications and comorbid conditions that they had. But as far as being added onto one, after they had been matched, they didn't discuss that.
All right, any other questions for our presenter? All right, so thank you for your presenting this important study. I think it helps us to answer a lot of questions that we always ask about the drug-drug interaction. So perhaps we need more studies in the future, but I think it's a good start for the specific topic. Our next presenter is Dr. Zoe Chasen. Dr. Zoe, she's a PGY2 critical care resident from the University of Iowa Hospice and Clinic. And she's presenting our second study, which is the early celecoxib use in spontaneous intracerebral hemorrhage is associated with reduced mortality that was published recently in Neurocritical Care. So if you want to present your slides, feel free to.
Okay. Can you all see my slides okay? Okay, perfect.
Yes.
Thank you for that introduction. Like he said, my name is Zoe Chasen, and I'm the current PGY2 critical care pharmacy resident at the University of Iowa Healthcare. And the article I'll be reviewing today is titled Early Celecoxib Use in Spontaneous Intracerebral Hemorrhage is Associated with Reduced Mortality. So the objectives of today's presentation are to review intracerebral hemorrhage, or ICH, epidemiology, pathophysiology, and management, to describe the current role of neuroprotective anti-inflammatory agents in the treatment of ICH, and evaluate primary literature regarding the role of celecoxib and ibuprofen in spontaneous intracerebral hemorrhage, or SICH. So first off, we're going to start with a little bit of background on both intracerebral hemorrhage and then the role of anti-inflammatory agents such as COX inhibitors in this disease state. So looking at hemorrhagic stroke overall, we know that there are both ischemic and hemorrhagic strokes. While ischemic stroke is going to be our most common type of stroke, hemorrhagic strokes still account for 10 to 15% of all strokes. It does have the highest mortality rate of any type of stroke at 50%. And for our patients that do go on to survive their initial stroke, there is significant morbidity associated with it. Overall, hemorrhagic stroke, like all strokes, is a medical emergency and must be promptly evaluated and treated to provide the best possible outcomes for our patients. Looking at ICH more specifically, it is the most common type of hemorrhagic stroke and accounts for 85% of hemorrhagic strokes overall. It's simply defined as bleeding within the brain tissue, and we can see a collection of blood there on the CT scan of a brain that represents where the ICH has occurred. ICH can further be divided into two subclasses based on etiology, so either primary or spontaneous intracerebral hemorrhage or secondary intracerebral hemorrhage. Primary is going to be our most common type and will also be what we're focusing on today, but it is due to a cause other than some sort of structural malformation or abnormality. The most common cause of primary or spontaneous intracerebral hemorrhage is going to be hypertension. For secondary intracerebral hemorrhage, this is due to some underlying structural pathology or abnormality, which could be from different things such as vascular lesions, malformations, or malignancies. Talking about spontaneous intracerebral hemorrhage pathophysiology, we have this initial hemorrhage in the brain. With this, there's hematoma expansion and further damage caused due to tissue disruption, mass effect and intracranial pressure increases, thrombin, erythrocyte lysis, and overall, this all leads to a breakdown of the blood-brain barrier, edema, and ultimately neuronal damage. We also have overall inflammatory reactions which further contributes to this damage. In spontaneous intracerebral hemorrhage, it's really this release of inflammatory markers that leads to perihematomal edema, secondary injury, and worse outcomes, which can include seizures, ventilator dependence, neurologic dysfunction, and death. Overall, some of the most well-defined risk factors for these poor patient outcomes includes hemorrhage volume and edema. Looking at the management of spontaneous intracerebral hemorrhage, overall, as I mentioned before, it is a medical emergency. So if you suspect a patient may have one, you want to make sure that you have an adequate airway and obtain one if a patient is unable to protect their airway. And you also want to get imaging to rule in or rule out spontaneous intracerebral hemorrhage. This is most commonly done with a non-contrast head CT. After, there are some general treatment principles, which can include getting a brief medical and medication history, obtaining blood pressure control to further prevent any spread or growth of the hematoma. And this is most commonly a target of less than 140 to less than 180 systolic blood pressure. You also want to obtain hemostasis, which may involve reversing anticoagulation or giving specific blood products. And finally, considering surgery or extraventricular drains. And if your center is not capable of this, it's important to transfer to a center that is. With this, we can see there's really an area that is not discussed on our pathophysiology overall that is potentially an area of interest to further promote better outcomes. And it's really looking at that inflammatory reaction. A lot of the other areas of this pathophysiology are currently targeted with the existing treatment. This is one that we don't really have addressed in most treatment algorithms, and it's going to be what we're focusing on today. So it's the use of neuroprotective anti-inflammatory agents. Looking at celecoxib as a whole, the bulk of the medication we'll be talking about is celecoxib today, but we'll also be talking a little bit about ibuprofen. Celecoxib specifically is a COX-2 selective NSAID. It's theorized that the COX-2 overexpression in spontaneous intracerebral hemorrhage is essentially an overexpression of the COX-2 that neurons and astrocytes express at baseline. This overexpression promotes synthesis of prostaglandins, creates a pro-inflammatory response with free radical formation and glutamate release, causing worsened outcomes, edema, and ischemia. Since COX-2 is a selective NSAID, like all NSAIDs, it will block that COX-2 pathway, preventing that inflammation and inflammatory response. Other NSAIDs that are not selective, such as ibuprofen, will still block that COX-2 pathway, but will also block COX-1. Overall, celecoxib and other NSAIDs are hypothesized to then reduce perihematomal edema and promote neuroprotection through the anti-inflammatory effects. Next, I wanted to briefly review a couple of the studies that are currently out there regarding the use of NSAIDs in this population. As you can see, there's not a whole lot of literature available, but I did want to highlight these 3 studies, which are the bulk of the literature. The first study was done in 2009 by Park and colleagues and looked at 34 patients admitted within 48 hours after onset of primary ICH. They looked at an intervention of celecoxib 400 milligrams per day for at least 7 days versus placebo. Their outcome found that celecoxib significantly reduced volume of edema with no difference in adverse events at 7 days. A study a few years later by Lee and colleagues was a multi-center randomized controlled trial of 44 patients with spontaneous intracerebral hemorrhage within 24 hours of onset. They looked at celecoxib at a different dose of 400 milligrams twice daily for a different duration, 14 days versus standard of care. They found similar results that perihematomal edema expansion was significantly lower in the celecoxib group at 7 days. While we know that edema and expansion are going to be 2 markers of generally worse outcomes, we don't really have any representation of actual impacts on our patients, such as mortality or morbidity. And then looking at a little bit different population and intervention, a study by Ironside more recently looked at 589 adult ICU patients with primary ICH. They compared patients with ICH that had prior to admission daily COX inhibitor use within 7 days versus patients that did not have that daily COX inhibitor use. While the sample size here was a lot bigger at 589 patients, one thing I wanted to point out is that only 1 patient was on celecoxib and 34 were on ibuprofen or a combination of ibuprofen and another NSAID. The vast majority were on aspirin. However, they found no difference in modified Rankin scale or recurrence of ICH at 90 days. We will be referring back to these studies a little bit when I talk about some of the strengths and limitations of other studies, so just keep those in mind. With this limited literature in mind, this leads us to the purpose of this study, which is to examine the impact of celecoxib on spontaneous intracerebral hemorrhage outcomes and also to examine the impact of ibuprofen on spontaneous intracerebral hemorrhage outcomes. So next up, we're going to talk a little bit about the methods of this study. This was a retrospective propensity score match TriNetX database review. For those of you that are not familiar with TriNetX database, it is essentially a database of a lot of different large health centers globally. With this, there are some limitations. So the researchers don't have full access to the charts. There's limitations on what they can pull. There's also some different things in place to help promote confidentiality. So if things in that they try and pull for either their baseline characteristics or results occur in less than 10 patients, but it occurs in at least some patients, so anywhere between 1 and 9 patients, it then gets rounded to 10. So if at any point during the results you see the number 10, that could potentially be anywhere between 1 and 10 patients. If it is marked as 0 patients, it's truly 0. And then if it's any higher than 10, it is actually representative of what they found, but potentially that could throw off some of our data a little bit just due to that rounding. Ultimately, they included patients with a diagnosis of spontaneous intracerebral hemorrhage via ICD-10 and RX norm codes. Looking at the interventions, they performed 3 different analyses. The first compared patients that were administered celecoxib within 5 days of spontaneous intracerebral hemorrhage diagnosis versus those that did not receive celecoxib within those 5 days. Our second group is similar, with patients that received ibuprofen within 5 days of spontaneous intracerebral hemorrhage diagnosis versus those that did not have any administration of ibuprofen in those 5 days. And then finally, our third analysis includes patients that received celecoxib but no ibuprofen within 5 days of diagnosis, compared to patients that received ibuprofen but no celecoxib within 5 days. Due to the retrospective nature of this study and the use of the database, there are no further details on dosing, how many doses they received in general, and the duration or timing. Our primary outcome is going to be mortality at 1 year, and secondary endpoints include ventilator dependence, tracheostomy, PEG 2 placement, craniotomy, PE, DVT, ischemic stroke, TIA, MI, and seizures. For statistical analysis, all analyses were evaluated as exploratory analyses. Propensity score matching was used to help reduce confounders as best as possible and match groups via greedy nearest neighbor algorithm with a caliper of 0.1 pooled standard deviations. An alpha of less than 0.05 was considered significant for all endpoints. Primary outcome analysis utilized survival analysis with hazard ratios and Kaplan-Meier survival curves to show 1 year survival for patients treated with celecoxib, ibuprofen, or neither. For secondary outcome analysis, odds ratios were used to evaluate non-categorical variables, and chi-square and logistic regression were used for categorical variables. So as we move into the results section of this journal club, we'll be looking at each different analysis individually. So to start off, we're just going to be talking about those patients that received celecoxib within 5 days of diagnosis versus those that did not receive any celecoxib. Looking at our baseline characteristics, we had 833 patients in each group. The average age was about 60, about half were female, and 3/4 were white or Caucasian. They also collected information on certain diagnoses, so there was no difference in hypertension, lipidemias, diabetes, ischemic heart disease, obesity, nicotine dependence, kidney or liver disease. One thing I did want to point out, just more for reference, is that the rate of hypertensive diseases was about 68 to 71%, which aligns with what we know with hypertension being the most common cause of spontaneous intracerebral hemorrhage. Overall, no differences in these baseline demographics. They also collected information on different procedures and medications that may have occurred. So there was no difference in receipt of aspirin, warfarin, clopidogrel, apixaban, rivaroxaban, ticagrelor, dipyramidol, prasugrel, ticlopidine, and intubation. Looking at our primary endpoint of mortality at 1 year, we have this Kaplan-Meier curve with the x-axis time in days, and the y-axis is probability of survival at the time points. The red line represents patients that received celecoxib, and blue is for patients that did not receive celecoxib. We have a mortality at 1 year of 13.33% for patients receiving celecoxib and 17.77% for those that did not receive celecoxib. This has a hazard ratio of 0.74 and was statistically significant in favor of patients receiving celecoxib. You can really see the farther out there you get, the lines really split even more on that Kaplan-Meier curve. Looking at our secondary endpoints, there were no statistically significant differences between any of these, including ventilator dependence, tracheostomy, PEG tube placement, craniotomy, PE, DVT, ischemic stroke, TIA, MI, and seizures. We did see a slight trend towards higher rates of tracheostomy in celecoxib group and MI in the no celecoxib group, but overall none of these were statistically significantly different. So next we'll move into our second group, which is the patients that received ibuprofen within 5 days of administration or of diagnosis and patients that did not receive ibuprofen. Our sample size here is even larger at 4,668 patients per group. Average age is a little bit younger at 51 and about 43% were female. 65% were white or Caucasian, and we have no differences in baseline characteristics here. Looking at our diagnoses, again, we have no statistically significant differences between any of these, and we do have a pretty high rate of hypertensive diseases at about 57 to 58%. Looking at our procedures and medications, we do have a trend towards higher rates of clopidogrel use in the ibuprofen group, but this is not statistically significant. But what we do see is a higher rate of ticlopidine use in the no ibuprofen group. Ticlopidine, for those that are not familiar with it, is a P2Y12 inhibitor that is no longer on the market in the United States. The big thing I wanted to point out here is that we see that 0 patients had an ibuprofen group, which is going to be truly representative of how many actually received it, but we do see the number 10 for the no ibuprofen group. So again, this could truly be 10 patients, or it could be anywhere between 1 and 9 due to rounding. So while we don't know for sure that it's statistically significant, we should treat it as such. Looking at our primary endpoint, the red line again represents the patients that received ibuprofen, and the blue line represents patients that did not receive ibuprofen. We see a mortality at 1 year of 17.07% for our ibuprofen group versus 18.1% for our no ibuprofen group. This has a hazard ratio of 0.926 and is not statistically significantly different. We can see those lines are a lot closer together on our Kaplan-Meier curve. Looking at our secondary endpoints, we do see 2 differences here with higher rates of tracheostomy and PEG tube placement in the patients that received ibuprofen. Other than those secondary endpoints, there were no statistically significant differences. So finally, we will move into our last group, which is patients that received celecoxib and no doses of ibuprofen within 5 days of ICH diagnosis versus those that received ibuprofen and no doses of celecoxib within 5 days. So our sample size here is 772 patients per group, average age about 63, again, half are female and about 60 to 61% are white. For our diagnoses here, again, all of these baseline characteristics are similar between groups, but one thing I thought was just really interesting more than anything is that the rate of hypertensive diseases is only about 43 to 45% in this patient subset. Looking at our procedures and medications, we do see 2 differences here with higher rates of ticagrelor use in the celecoxib group and prasugrel use in the ibuprofen group. Again, due to rounding, these may not potentially actually be statistically or clinically significant, but it is something to consider, and we should treat it as being different between groups. Looking at the primary endpoint, the red line represents our patients that received celecoxib, and our blue line represents patients that received ibuprofen. We see a mortality at 1 year of 14.25% for our patients receiving celecoxib and 20.47% for patients receiving ibuprofen with a hazard ratio of 0.64. This is statistically significantly different, and we can see those lines on the Kaplan-Meier curve are even more spread out than the 2 previous ones. Looking at our secondary endpoints, there are no statistically significant differences here between groups. So finally, we'll move into the discussion and critique portion of the journal club. The authors ultimately concluded that early celecoxib use after spontaneous intracerebral hemorrhage is associated with decreased mortality at 1 year, and the use of celecoxib in this population does not result in significant increases in adverse events. As far as relevance to practice, I think one of the things to note here is that this really is the largest study to date evaluating NSAID use in spontaneous intracerebral hemorrhage population, but there is ultimately a need for future prospective studies to further support and implement the use of celecoxib after spontaneous intracerebral hemorrhage for some of the reasons we'll discuss on the next slide. So for the critique, we'll start off with the strengths, and I think, as I alluded to before, the large sample size is a huge strength of this study. Ultimately, we saw patients anywhere from 700 to thousands, whereas a lot of the previous studies were in, only a sample size of 30 or 40 total. Even that larger study, we looked at the third of the three I presented, had about 500 patients, but again, only 35 of them would have qualified for this study. Additionally, I think the propensity matching to get baseline characteristics well matched between groups was overall a strength. We did see potentially some differences between groups, but again, these could potentially be due to rounding. And overall, I think despite that, they were overall pretty well matched. Finally, I also really liked that they used patient-centered endpoints. Those two previous studies I presented initially used, markers of things that we generally know lead to worse outcomes, but ultimately we can't completely extrapolate it to actually having the worst outcomes. So it was nice here to see, obviously a marker of mortality all the way out at 1 year, which I think was another strength, how far out they went, but also looking at different markers of morbidity. As far as weaknesses, I think the retrospective nature is definitely a huge weakness. As we know, randomized control trial is going to be the gold standard, and ultimately we just can't fully account for a lot of confounders. And I think the use of that database also kind of led us to not only some of the weaknesses of it being retrospective, but some of the other weaknesses I'll discuss. I think probably the biggest weakness in terms of our ability to actually apply this to clinical practice is that we don't know the dosing, duration, and timing of treatment. And the authors did address this, saying that they have no idea, they were unable to pull this due to the nature of the database. So we really don't know how aggressively we need to dose it, how long it needs to be continued for. And then as far as timing of treatment, they just, it's only known that it's within those 5 days of diagnosis, but we don't know how soon after it is safe or effective to start using it. Even the two previous studies I presented earlier both had different dosing and duration. So I think that's definitely something that is a weakness for our ability to actually change our practice. Another weakness is that there's no baseline characteristics of prior to admission NSAID use. We see, with it being retrospective, we see that it was implemented, but we don't really have any idea why. Potentially, this could have been implemented and used in a lot of patients if it was a home med, but it could have also been used for the anti-inflammatory properties. So I think that would have been nice to have that baseline characteristic to potentially see, give us a better idea of why it may have been started. The third study I initially presented, gives me a little bit of a better feeling that potentially it's not going to affect the outcomes of the patients too much if they did use it prior to admission, but ultimately it is still a limitation. I think one of the other really big limitations here is that there's no baseline severity of ICH reported. Again, this was a limitation of the database, but it would have been really nice to have a GCS score, ICH, hematoma volume, or something. I do think we can infer a little bit that given the low mortality rate, with the maximum one being about 20% compared to what's generally reported closer to 40 or 50%, that likely these patients had a little bit more mild to moderate ICH, but ultimately we don't really know that for sure. So we don't have a great understanding of exactly the population to implement this in. And finally, again, while I did appreciate the endpoints in general, I think one thing that could have strengthened it further was including functional outcomes, such as modified Rankin scale or discharge disposition. But overall, I think that was probably the only endpoint that I really would have liked to see that they didn't have. So finally, my takeaway points for this study, I think celecoxib could be an emerging adjunct therapy for likely mild to moderate spontaneous intracerebral hemorrhage, but ultimately further studies are really needed to make significant practice changes. As right now, I don't really have a great idea on what dosing strategy to use, how long to use it for, and how soon after the stroke to implement it. And additionally, getting a better idea of the patient population will allow us to further make significant practice changes, but likely it will be in that more mild to moderate group, at least with the information we have now. One thing that I do see is on the horizon is a study recruiting at National Taiwan University Hospital, which is looking at initiating celecoxib 200 milligrams per day within 6 hours after ICH for 21 days. So a little bit different dosing and duration as some of the previous studies. But I think ultimately, if that study had similar results to this study, it could be potentially making me actually be closer to changing my practice with this. So with that, I am happy to answer whatever questions you all may have.
Thank you so much, Zoe, for your presentation. It's a very interesting topic, and hopefully we can see more in this area. Everyone feel free to post your questions in the chat section of the Zoom, and don't forget that you can continue the discussion on Twitter or X using the hashtag NCSPharmJC. I'll go ahead and get started. I'm actually also curious about the ibuprofen portion. Did the authors discuss or explain why there was an increased risk of PEG tube placements or tracheostomies in that specific cohort?
They didn't really address it in this study. I didn't necessarily see any reasons that made a whole lot, made it that seemed very clear of why potentially that did occur. It kind of made sense to me that likely if you were getting a tracheostomy that you might be getting a PEG tube along with it. So I don't think it was too surprising to see like that both of them were increased, but they didn't really talk about the mechanism between like why that may have happened for either or both of them.
And then the other question I had is the choice of the duration on the initiation within 5 days. The previous studies were like, I think around 48 hours, correct? So is there a rationale why they chose that time frame, or is it because it's a retrospective design of the study that they chose that time frame? Did they discuss any information about that in the study or the supplementary appendix?
They did not describe that either. It would, to me, based on just the pathophysiology of spontaneous intracerebral hemorrhage, make sense to start it a little bit earlier than that, like those other studies did and that upcoming one did. So it would be interesting to see how they landed on 5 days. I'm not sure, again, if that's potentially a limitation of the database, that maybe they couldn't pull like a more narrow time frame than that, but potentially that could be it. But I would think that likely starting it earlier would give us potentially more of an effect of it, but they didn't really comment on it.
All right, any other questions for Zoe? I guess one last question. Do you feel like if initiation of celecoxib at the moment would be appropriate, or you feel like it needs some more extensive data, especially that this study had large number of patients that were included in the study?
Yeah, I probably won't start, recommending it for any of my patients just because first of all, I don't really know how to, again, dose it, how soon after we should start it. I think if we have a patient maybe a few days out, like within 5 days, who's really adamant about wanting their home celecoxib restarted, I might be a little bit, I'm not going to be super resistant about starting it as I feel like it's likely safe. I just don't think I have enough information now to use this widespread in every patient. But if they do want to start it for whatever reason, I'm not going to hesitate, really. I think it would likely be okay and safe to do so.
Yeah, I agree with you. I think the current data support reinitiation of home medication, or if they need to use celecoxib for any reason after an ICH, still be appropriate. All right, I don't see any other questions for our both presenters. I would like to thank everyone for attending today, and thanking both our presenters, Dr. Jan and Dr. Zoe, for their presentations. And hopefully we can see everyone next month in the next iteration of the NCS Pharmacy Journal Club. Thank you, everyone.